Now it is my pleasure to introduce Dr. Andrea Russo. I met Andrea in 2002 when I went to Philadelphia to do a fellowship in electrophysiology, so she contributed to my training in electrophysiology. We spent many days working in the lab, and now she became the president of the Heart Rhythm Society, so it's really a pleasure to have you here. When we were planning to have this topic in this symposium, I immediately think about you because I know your research in this topic, in devices, in ICDs and mortality in women. And I'm really glad that you accept the invitation, really. So it's really a pleasure to have you here, and thank you for coming.
Well, thank you. Thank you. It's a pleasure and an honor to be here, and really I appreciate it. And really congratulations to all you, the organizers, for putting this on. It's been a terrific morning. And other countries, including the US, should kind of exemplify what you've done here. Here are my disclosures. So I'm going to talk a little bit about, just briefly, on the epidemiology of sudden death, talk about ICD outcomes, including transvenous and subcutaneous devices, a little bit about CRT outcomes, and then mention sex differences in utilization. So you can see here, this is from the Framingham study that looks at, these are people who didn't have any coronary disease or anything in the beginning, and they were healthy young people. And as they got older, you could see here the incidence of sudden cardiac arrest or sudden death here increases with age, as you might imagine, but at each given age group, you could see men in green and women in pink. There's always a lower incidence in females compared to males. And if you look at the etiology or the presenting rhythm at the time of cardiac arrest, you could see women here on the left, men on the right. More often, men present with ventricular tachycardia or ventricular fibrillation, and women more likely present with asystole or pulseless electrical activity. This looks at the incidence of sports-related sudden cardiac arrest. And so you could see here that just a minority of individuals who have a cardiac arrest during sports activities are women, only 5%. And you could see here the age groups, but very few. Blue are women, and males are in green. And women are more likely to have no underlying structural heart disease or have non-coronary disease in these sports-related sudden deaths. Similarly, if you look at the types of structural heart disease in men and females of all cardiac arrest survivors in this particular study, you could see, again, men are more likely to have coronary disease and women are more likely to have non-ischemic disease or no structural heart disease. So what about ICD therapy? And so as alluded to, I've had an interest, this is all near and dear to my heart, this whole topic of arrhythmias and sex differences. You can see the first study was first primary prevention ICD trial, or one of the first that looked at the sex differences in outcomes. In this study, there were only coronary disease patients, and they had a low ejection fraction, 40% or less, and they had EP studies, so we would bring them in the lab and we'd induce arrhythmias in some, and if you had inducible ventricular tachycardia, you were eligible for randomization to EP-guided therapy or just standard medical therapy. So this line here is the control group in terms of outcome. Related to the primary outcome in this study was cardiac arrest or death from arrhythmia. You could see that the control compared to EP-guided therapy are those two lines. The only people with the EP-guided therapy that benefited are those who received a defibrillator. Now, unfortunately, only 10% were women in this trial. And this is partially at least due to, there are differences in substrates, but even though they all had coronary disease, to get enrolled in the trial, you needed to have inducible sustained ventricular tachycardia. And for some reason, women are less likely to be inducible with the same type of heart disease than men. And not just this study in MUST, but in other studies have shown that also. An overall outcome in this trial, men and women in terms of total mortality did not differ, but there were very few women, 68 in this large trial. A study, this was a much larger trial called the Sudden Cardiac Death and Heart Failure Trial, looked at patients who are individual subjects who had both ischemic and non-ischemic disease were included. The ejection fraction cutoff was 35% or less, and they had class 2 or 3 heart failure. And in this study, they were randomized in a 1-to-1-to-1 fashion, amiodarone, placebo, or ICD. And in this particular study, only the patients who received an ICD had a benefit compared to placebo, and that was a reduction in mortality by 23%. In this study, only 23% were women. And if you look at the initial subgroup analysis, and this is just the pre-specified subgroups, you got the feeling here that men benefited from an ICD, but women, this cross 1 here, didn't seem to benefit. So we thought we'd delve into that a little more detail and compared in a sub-study, a post-hoc analysis, men and women. Women were more likely non-Caucasian, more likely to have class 3 heart failure, worse heart failure, more likely to have non-ischemic heart disease, more likely to have a shorter distance walked at the time of enrollment for the 6-minute walk, so they were a little bit sicker at enrollment. They had a shorter duration of heart failure and less likely to have atrial fibrillation. If you look at the overall outcome, despite the fact that women were actually sicker at the time of enrollment, you could see here that overall mortality was lower in women than in men. And so this was true overall in the study. It was also true in the placebo group with a trend in the amiodarone group. But if you look at the ICD group, you could see there's no difference in mortality between men and women, so it wasn't lower. No differences in ICD implant complications in men versus women, and no differences in appropriate shock therapy for ventricular tachycardia or ventricular fibrillation in women versus men. So, that suggests that maybe ICD therapy has a greater benefit in men than in women, possibly. There were, sicker, the women, at least the factors looked at, women were sicker, they were more likely to have class 3 heart failure. However, that was, adjusted for in the multivariate analysis. Or maybe women truly benefit less from an ICD, maybe because by the time they have heart disease, they're older, have more comorbidities, maybe there's competing risks at that point. Or maybe, as we saw in the sudden cardiac arrest occurrence in Framingham and in other studies, maybe they have a lower risk of arrhythmia susceptibility. And in addition, there was a lower placebo death rate in this study, so clearly smaller numbers of women enrolled, so the trial was, probably not powered to really see a difference. And if you look at all, a lot of the trials here, and this is a secondary prevention trial here, AVID, these are coronary disease trials, definite and SCUD have to included non-ischemic, but even in all these trials, look at the percentage of women is very low, right? In the 20s, definite was only non-ischemic, so it was a little bit higher. Look at the number of ICDs received in these studies, so women underrepresented in these trials clearly. So someone did a meta-analysis, and there were over 7,000 individuals, 22% were women. Men on the top clearly had a benefit of ICD therapy. Overall, even in the meta-analysis, not a significant, although a trend, toward ICD benefit. So in SCUD-HEF, what we did is initially we went back and looked at if women have the same benefit as men from ICD therapy, how many subjects were needed? Well, you would need to have, over 3,100 subjects to show a benefit. So clearly, that was underpowered. So what about real-life data? So we have registries. In the US, we have something called the NCDR ICD registry, and we looked, this is over 38,000 ICD implants, 25% women, and these are just, we looked at the primary prevention patients, and then we did follow-up using our Medicare, which is the payer for 65 or older individuals. And we saw that women actually in this also had greater comorbidity because they're more likely to be older by the time they get their ICD. But in this registry, overall, women actually looking at, without any adjustment, women had a higher mortality rate than men. But after adjusting for differences in baseline characteristics, there was no difference in overall outcome. And these are only individuals who received an ICD. Now, what about appropriate ICD intervention? So if patients have ventricular tachycardia or ventricular fibrillation. A meta-analysis of the multi-center trial shows here that overall women are less likely to have therapies for ventricular tachycardia or ventricular fibrillation than men. Again, maybe getting at the underlying susceptibility for arrhythmia. Another one, this is another prospective, it's a payer in Canada. They follow patients in a registry. Again, they also showed that women were less likely to have appropriate therapy for VT or VF. In addition, this is a European, a bunch of registries, 14 registries in Europe, similar findings. Appropriate ICD shocks occurred in 8% of women and 14% of men. So pretty consistent among multi-center randomized trials as well as in the registries. So why might that be? And we heard a talk as to differences between men and women. Well, there's different types of heart disease. Women who have ICDs are more likely to have them for non-ischemic etiology because it takes longer for them to develop coronary disease. Arrhythmia susceptibility maybe is different in men and women. There are differences in hormonal effects, autonomic tone, ion channels, cardiac structure. Maybe they have a different response to reverse remodeling. We saw a little bit earlier too about fibrosis, different in men and women, and competing comorbidities. So we don't really know, but these are some possibilities. What about CRT, cardiac resynchronization therapy? Well, this was one of the first studies to show it's looking at pacers, biventricular pacers in men and women, and they were randomized to turning CRT on versus off. And they all had a wide QRS complex and heart failure, class 3 or class 4. In this study, actually, women had a benefit of CRT, marked benefit in terms of time to first hospitalization or death, whereas men did not, actually, interestingly. So women do better with CRT. Similarly, in MADE-IT CRT, over 1,800 subjects enrolled, low ejection fraction, less severe heart failure, class 1 or class 2. They were randomized to a CRT defibrillator or just an ICD without the biventricular pacing. And there seems to be here a suggestion that women benefit more from CRT. In addition, a wider QRS of 150 milliseconds or more benefit more from CRT. So looking into that a little further in this study, you could see here the overall outcome with respect to heart failure or death, stratified by sex and type of device, women with CRT defibrillators compared to those women with just ICDs without the VIV. You see a big difference in outcome. They do much better with CRT devices. Men do better with CRT devices too, but a little less of a difference. And this, suggests, and also in this study, they look at echocardiographic differences, and women tended to have better response in terms of reverse remodeling. Their ejection fractions got better. In a meta-analysis of all the different studies, both the randomized studies as well as registries and cohorts, prospective cohorts. So overall, women had a better outcome from CRT compared to men in terms of risk of death is shown here, overall better, as well as other factors like a reduction in ventricular arrhythmias. And if you look at in this study, the echocardiographic, the studies, 6 studies looked at echocardiographic parameters, show also that women have a better response to reverse remodeling. So their end diastolic volume improves more than in men, and their ejection fraction improves more than in men. So what about registries? So some real-life data now. Again, similar findings in our real-life registries in women and men. And in this registry of over 75,000 patients in the ICD registry. Heart failure, class 3 or 4 heart failure here, wide QRS of 120 milliseconds or more. Similar findings, CRT. With a defibrillator, women do better with a CRT, same as men, but again, a bigger difference in women compared to men. And then left bundle branch block. So we know that patients with left bundle branch block tend to benefit more from CRT. And if you look and you divide it up into, in this study too, dividing it up, again, CRT patients, women tend to have a much more of a benefit even than ICD therapy alone. And men had a benefit, but not as dramatic. If you have you just have a non-specific interventricular conduction block, less of an improvement with CRT in both men and women. And if you think about it, so why does a left bundle benefit more? Well, with the left bundle branch block, you have conduction delay. So instead of, this is normal here, you activate the septum from left to right, and you activate the ventricle in a more synchronous manner. And that you get from here to here in just about 40 milliseconds. If you have a left bundle, you have to activate the septum from right to left, and it's a more delayed activation that it takes a lot more time, 100 milliseconds, to get from the septum to the lateral wall, and the lateral wall is where you usually put your lead. So left bundles tend to have a better benefit of CRT. And it also, now if you look at cure restoration, and I'm bringing this up because our guidelines are very specific on cure restoration. If you look at individuals with the left bundle and heart failure, overall, if you look at the cure restoration, the guidelines highly recommend CRT for a cure restoration of 150 milliseconds or more. But if you only have 120 to 149 milliseconds, women still tend to benefit. And they have a high response rate regardless of whether they have this cure restoration versus this cure restoration, whereas men really don't benefit much with a lower cure restoration. This is also, so trying to look at why that might be. This particular study, I didn't show you the slides, but just they looked at LV mass or end diastolic volume, and these sex-specific differences really go away when you consider mass. So it's not sex alone, it's the mass of the left ventricle has something to do with the response to CRT. So if you look here overall, again, the individual patient data from 3 randomized trials, again, women, if you look at just the group of 130 to 149 millisecond cure restoration, they tend to benefit from CRT, adding the BIV device here, the LV lead. They benefit in terms of this is heart failure or death, heart failure, hospitalization, or death, whereas men really did not. Again, showing the benefit of CRT being greater in women than in men. And our guidelines are actually written, although the European guidelines do better than the US guidelines, some of it may be timing, they're a little bit outdated now in the US, but they really talk about this group of this middle of the road group with a lower level of recommendation for a CRT in that group. And in fact, in the US guidelines, they say it's a class 3 recommendation, not recommended if you have mild heart failure and a non-left bundle branch block with a cure restoration of less than 150. And clearly that's not true for women. Women still benefit from CRT in this group, and so we really could be underutilizing it for that purpose. And in fact, the document you saw earlier, the consensus document, the ERA consensus document, does warn against that you should still consider CRT in the more narrow QRS individuals. This looked at, what about scar? So we're looking at cardiac MRI findings. Interestingly, women have less scar in the left ventricle who get CRT or just ICDs than men. Part of that may be due to the fact that they more often have a non-ischemic origin to cardiomyopathy, but it may not be just that. And if you don't have a lot of fixed scar, you may be more likely to benefit from resynchronization therapy. So that might be one reason. What about complications? Overall complications in the NCDR registry, we looked at that, are higher in women than in men, significantly higher, and most of that is due to, as you heard a little bit earlier, most of the complications are due to mechanical things. So just like with ablation, women may have thinner-walled right ventricles, and you can see here tamponade or mechanical complications are the reasons for, and pneumothorax actually are the reasons for women to have higher complication rates. But if you use a totally subcutaneous device where you don't put anything in this small vasculature, just like the coronary arteries are small, the veins are smaller, and more likely to get pneumothorax. No difference in the subcutaneous ICD, no difference in complication rates between men and women. Same thing with CRT. Women have a higher complication rate with cardiac resynchronization therapy compared to men. So what about usage of ICDs and CRT in men and women? Well, again, underutilized. Overall, you can see that even though the usage, this is years ago, but the usage was increasing in white men at a pretty high rate. Black women had less of an increase in ICD usage. In the US, there's guidelines that look at, to get with the guidelines, American Heart Association, that looks at sex and racial differences in ICD recommendation for people who meet criteria. With a low ejection fraction, you can see white men, 44% got ICDs, and lower in women, and very low in black women. Same thing, and this is another outpatient. This is an outpatient performance improvement program, over 15,000 patients. And although only half of the people overall who met criteria for an ICD got it in this trial, you could see the gap here. Women, again, less often recommended ICD therapy than men. And this, even after multivariate analysis, still panned out. And so, we'd say there's all these differences, and, is it just a difference? Because part of it may be to less women meet criteria for the ICD, or they meet it at an older age when they have more comorbidities. Is it truly bias, and the physicians are not even offering it to them? That's a possibility, and we think that's part of it. Or do patients refuse? There's not any really good data to show that women are more likely to refuse than men. So in conclusion, sudden cardiac arrest, there's gender differences in epidemiology of sudden cardiac arrest, and then women just have lower rates of sudden cardiac arrest at any given age group than men. Certainly women are underrepresented in ICD trials, and then some studies suggest that there's potentially less of a mortality benefit of ICD therapy in women than in men, but really these were underpowered to show, they weren't powered for women because there was a small number of women enrolled in these trials. There are higher complication rates in women with transvenous devices that isn't seen with subcutaneous devices, and women tend to, in most of the studies, experience less appropriate VTVF during follow-up with their devices. In terms of CRT, again, underrepresented in the CRT trials, in most of the trials, and they're less likely to receive CRT in some of the trials, but they're more likely to benefit from CRT than men. And even at a shorter QRS duration, they're more likely to benefit. So, we really, need to understand more. We need continued research to understand why there's these sex differences. Is it hormones? Is it ion channels? Is it genetic? Who knows? Or a combination of above. And we have to be careful when we're developing our guidelines, because if studies have underrepresentation of women, we want to make sure that we're not excluding women. Post hoc analyses are good to at least look at, like QRS duration. We're maybe excluding therapy in women that might benefit them because we're basing the results on men. So to ensure, the bottom line is to ensure that we're delivering evidence-based care, we really, to both sexes, we need to be sure that we enroll women in all these trials at increasing numbers. Thank you.